Now, we all know that irrespective of the lung or any part of the body, there is a small amount of fluid that actually moves into the tissues. Now, in the lung, this is particularly referring to the fluid that is in the interstitial space, the intracellular fluid, alveolar space, and the lymphatics. But remember, it does not include fluid in the pleural space. Now, the hallmark of critically ill patients, especially those with severe sepsis who are going for ARDS or in ARDS patients, burns patients, there is a breakdown of this system, as a result of which interstitial fluid in the lungs actually increases. Now, for many years, this entity about extravascular lung water was a form of something which was experimental, because there was no way that we could get this parameter at the bedside. But with the availability of transpulmonary thermodilution catheters, today looking at extravascular lung water and the pulmonary vascular permeability is a clinical reality which we can use at the bedsides. And over the last few years, what we have seen is that this extravascular lung water using transpulmonary thermodilution has undergone extensive validation studies, as well as we have gone beyond that. It can be used as a prognostic indicator, and today what we are looking at is that whether with these values can be used in the management of patients, particularly referring to lung-based management or fluid management. We all know about Starling's principle. In the lungs, there is a small amount of fluid that is actually going out in the tissues at all the time. This is based on the hydrostatic pressure that tends to flush the fluid into the interstitial space, and the oncotic pressure that tends to retain it. Normally, this fluid that goes into interstitial tissue doesn't go into the alveolar space because of the efficiency of the lymphatic system, as a result of which the alveolar spaces remains clear and able to do its function, its work. Now, however, the recent validation studies which has looked at extravascular lung water has shown us that the normal value for extravascular lung water in the lung is about 7 ml per kg, and anything more than 10 ml per kg should be considered as an abnormal value. Now, why should fluid go into the extravascular lung space in a more than normal value? 3 reasons. One, your hydrostatic pressure is high, like for example, a patient with severe LV dysfunction, where the LV cannot push out fluid. The left atrial pressure and the back pressure cause an increase in the hydrostatic pressure, and fluid moves into the tissues. Secondly, if your oncotic pressure is low, the transpulmonary gradient actually increases, and this can actually move fluid into the tissues. But most importantly, the integrity of the alveolar capillary membrane has to be respected. Any breakdown in the alveolar capillary membrane can cause more fluid to actually go into the tissues. For example, if you see this chart, as the hydrostatic pressure actually goes up towards the right, you will find more fluid going into the tissues. But the worst situation is that when your alveolar capillary membrane is damaged, the amount of fluid that goes into the tissues become more and more at low hydrostatic pressure. So, the worst situation is there where you have a higher hydrostatic pressure and a very poor high permeability of the alveolar capillary membrane. Of course, there are compensatory mechanisms like the lymphatic system, as well as an active ion fluid transport mechanism that is present in the alveolar capillary membrane, but these are often overwhelmed. Now, how do you measure? Historically, the only way to measure the extravascular lung water was gravimetry, which is an autosep study. You take out the wet lung, weigh it, and then dry it out and see what is the weight of the lung. But this was considered as the gold standard for many years. You have clinical signs, basal crepitations or rhonchi that you can hear. You can look at the X-ray and say whether the lung water is extinct, but there are a lot of interpersonal variations in this. CT scan and MRI can tell you amount of extravascular lung water that is present, but is it a clinical option in a critically ill patient at the bedside? Then we have the electrical impedance tomography, which is coming up, but more importantly, what we nowadays use very frequently is the lung ultrasound techniques. Definitely can tell you, but the major disadvantage is that we look at specific areas, it does not tell you about extravascular lung water as a whole. And at present, we do not have a grading system using ultrasound techniques to say that so much what is the extravascular lung water. So, the first breakthrough came with what is known as a transpulmonary thermodilution dye dilution technique, in which there was simultaneous injection of both a dye as well as cold injected into the central superior venal cava. But this has turned out to be very cumbersome. But the thing that has really changed our outlook on this is the transpulmonary thermodilution catheters, which the cardiac anesthesiologists often use to measure the cardiac output. Now, this is very simple technique. You inject ice cold saline 10 to 20 ml through the SVC, and you have a thermistor tipped femoral artery catheter that is placed through the femoral artery in the lower abdominal aorta, and this cold injectate, as it goes down, there is a difference in temperature. It generates what is known as a thermodilution curve, and using the Stewart-Hamilton equation, you generate what is known as a cardiac output. Now, the further steps that we use are based on another equation called the Newman's principle. Now, let us see what happens. Now, once we know the cardiac output, the volume of distribution of the cold injectate between the site of injection and the site of detection of temperature depends on what is known as the mean transit time. I don't have an indicator. It's the time from which you inject the drug till that point where the downslope actually starts. Now, if you multiply the cardiac output, if you multiply the cardiac output with the mean transit time, you get what is known as the intrathoracic thermal volume, which means the volume of blood that is present in all four chambers of the heart plus the lungs, which includes extravascular as well as the intravascular chambers. The second principle that we have to understand is that when you have a series of mixing chambers of different sizes, for example, small one, large one, intermediate one, the downslope of this thermodilution curve is primarily dependent upon the largest of these chambers. So, you can actually find out what is the blood volume in the largest chamber in this mixing chambers. Now, what is the largest chamber in the heart, in the thorax? It is the lungs. So, with this principle, if you multiply the cardiac output with the downslope time of the thermodilution curve, you get what is known as the pulmonary thermal volume. Now, I am just going to represent it in a different way. The intrathoracic thermal volume is the blood that is contained in all the four chambers of the heart as well as the lungs. We can also find out what is known as the pulmonary thermal volume, which is the blood only in the lungs, extravascular plus intravascular. And if you minus the two, you get the blood that is contained in all four chambers of the heart, which is known as the global end diastolic volume. Now, today in cardiac surgery, we use this as a preload status of the patient. They are fixed values based on which we can hemodynamically manage the patient. Further studies have actually shown that if in addition to the four chambers of the heart, you also want to know what is the blood volume, the intravascular blood volume in the lungs, you have a formula which is multiplying the the GED with its global end diastolic volume into 1.25, you get what is known as the intrathoracic blood volume, which includes blood in all four chambers of the heart as well as the intravascular compartment of the lungs. And now it becomes very simple, and once if you subtract the intrathoracic blood volume from the intrathoracic thermal volume, you get what is known as the extravascular lung water. Now, we don't have to bother about all these things because today we have equipment which calculates all this and tells you automatically what is the extravascular lung water. Now, the second question that was debated a lot, how do you index it? Extravascular lung water initially was indexed to the actual body weight of the patient. Now, this tend to underestimate the actual extravascular lung water. For example, if you see earlier studies, you will find that in ARDS patient only about 25 to 35% of the patient had normal, only 25 to 35% of the patient had increased extravascular lung water. The reason was that the lung size is primarily dependent on the height of the patient rather than the actual body weight. Secondly, when you have a patient with severe sepsis and he goes into ARDS, you already fluid loaded him. So, it tends to again underestimate the extravascular lung water. So, people start looking at other things, and Huber and colleagues actually looked at actual body weight, predicted body weight and the height of the patient, and he said that height is the most important thing, but there are other studies which actually looked at the predicted body weight. When you remember that when you talk about predicted body weight, a significant portion of that formula involves the height of the patient. So, today when we talk about extravascular lung water, we are indexing it to the predicted body weight, because this has shown a significant correlation with various indices of lung injury, including the oxygenation index, the lung injury score, the dead space ventilation, etc., etc. So, a few aspects about lung water measurements. Normally, when you have a transpulmonary thermodilution catheter, we use 3 injectates. Each of these values are the values are averaged. Normally, if you want to get a good correlation, that the values between each of these should not vary by more than 12%. The ice cold saline should be injected into the SVC. You have techniques where you can inject into the femoral vein also, but the calculations becomes difficult. Now, the question was whether ice cold saline is as accurate as normal saline in assessing all this. Again, ice cold saline may have some advantage. It is more accurate when you look at the extravascular lung water. Two devices actually available. One is the MacWay, which I have not used myself. The other one is Edward Life Sciences, which we call the EV1000 or the volume view, which is freely available now, and although it is quite expensive, which is the one which is more commonly available in our country today. Both use the Stewart-Hamilton equation as the Newman equation. The only difference between the two machines is that the way in which they calculate the pulmonary thermal volume is slightly different, but there are studies which has compared the two machines and found no significant difference between them. A few caveats that we have to understand: the limitations of extravascular lung water. If you have massive pulmonary embolism, extravascular lung water measured by this technique is not right, because it underestimates the extravascular lung water. But when you look, you can have a similar situation in ARDS patients where the pulmonary arteries may be occluded because of high intrathoracic pressure, artery venous shunts, etc., etc. But clinical studies using extravascular lung water in ARDS patients shows that this is not important. Extravascular lung water assessed in ARDS patients is relevant. However, you cannot use it when you have a patient who has a pneumonectomy or a lobectomy, because it underestimates the extravascular lung water. Third one, ARDS patients. The type of ARDS may be important. Experimental studies have shown that it is reliable when you have homogeneous lung disease, but not in heterogeneous lung disease because of pulmonary artery venous shunting. Again, clinical studies used in ARDS patients have shown that is not very relevant. You can use extravascular lung water. The effect of PEEP is, it's very confusing. For example, if you use high PEEP, you can actually compress the microvessels, pulmonary microvessels, and actually underestimate the extravascular lung water. At the same time, if your PEEP is adequate, it opens up atelectated lung units. It will actually increase the pulmonary blood flow, and extravascular lung water can actually increase. Second, when you use PEEP, there is a high intrathoracic pressure. It can actually decrease the cardiac output and underestimate the extravascular lung water. And at the same time, it can compress the lymphatics and increase the extravascular lung water. So it is very difficult to predict how all this will interact in a particular patient. But one study by Patronati and colleagues have looked at ARDS patients in a wide range of PEEP values, and they found no significant difference in the extravascular lung water that was evaluated. The pleural efficient, and in fact, again, you can say that it is not very, as I said in the first slide, it does not include extra pulmonary fluid. The pleural efficient is not indicated. In fact, the study actually showed that if you do tapping, massive tapping of the pleural efficient, the extravascular lung water actually increases. This may be because of a hydrostatic pulmonary edema, or because the collapsed lung is actually increasing in size, as a result of which fluid can actually move out. In renal replacement therapy, it is not very, it doesn't affect the extravascular lung water, but you cannot use this in ECMO, and the complications of this technique is more related to the way in which, especially the femoral artery catheter, you have to be extremely careful, because the catheter is much bigger than the normal femoral artery catheter that you place. You have to be very careful when you use it in patients with liver disease, etc. The second point which we have to talk about is pulmonary vascular permeability index. Now, this denotes the volume of fluid that are actually passed out of the intravascular compartment to the extravascular compartment. It is a ratio between the extravascular fluid and the intravascular volume, and it is only reliable. Please understand, it is only reliable when the cold injectant is given through the superior vena cava. You cannot use it from the femoral vein. And the increase in pulmonary vascular permeability index is the hallmark of ARDS. And remember, the most important thing is that it helps extravascular lung water with pulmonary vascular permeability index is the difference between hydrostatic pulmonary edema and ARDS. In hydrostatic pulmonary edema, the pulmonary vascular permeability is always intact. The extravascular fluid that occurs increases in these patients because of high hydrostatic pressure. Whereas in ARDS, the pulmonary vascular permeability is increased, as a result of which there is an increase in the extravascular lung water. Both extravascular lung water and pulmonary vascular permeability are excellent indicators of mortality. In fact, studies have shown that it is able to, for example, extravascular lung water, specifically in ARDS patients, an increase in the extravascular lung water by more than 15 ml per kg index to body weight on day 1 of ARDS can predict that this patient is going to go into ARDS 2.5 days before any other indices of lung injury actually can show changes. Now, both extravascular lung water and the PaO2 both predict are prognostic indicators, but remember they tell you different things. For example, a patient with a low PaO2 in a patient with ARDS can be not only because of increase in the extravascular lung water, it can be due to other things. For example, pulmonary artery venous shunts, it may be because of atelectasis. So, you have to look at both the factors rather than look at only one thing. And the last thing is that extravascular lung water and the pulmonary vascular permeability predict mortality in ARDS with significant accuracy. Now, how to use it in the clinical picture? Now, the Berlin definition of ARDS does not include either extravascular lung water or pulmonary vascular permeability in any details. Now, but there is compelling evidence, at least when the next definition comes of ARDS, we can use these two parameters. For example, one is the pulmonary vascular permeability is increased pulmonary vascular permeability is the hallmark of ARDS patient. But do they mention it anywhere in the definition? No. How do they circumvent the problem? By saying that the pulmonary edema is because of in the absence of an increased left ventricular filling pressure. Now, if the pulmonary vascular permeability is included in that is because it is always there. In fact, studies have shown that up to only 45% of the patients who have ARDS have got 30% of the patients actually do not show an increase in the extravascular lung water. And if you look at the pulmonary, if pulmonary vascular permeability is included as a definition, it tells you with 100% specificity. Second, diffuse alveolar damage in ARDS patients. Studies have actually shown that 45%, only 45% of the patients who have ARDS actually shows diffuse alveolar damage. But if you look at extravascular lung water in ARDS patient, it can tell you with 99% sensitivity and 100% specificity that it is ARDS patients. And lastly, combining extravascular lung water and PVPI can be used as a prognostic indicator for development of ARDS in severe septic shock patients. So, this should be included. Second point, fluid management. We all know that to access fluid management today is not an option. Cumulative fluid balance in patients with a septic shock is associated with the increased mortality. We know about the FACT trial, which tells you a conservative fluid management decrease the number of days of mechanical ventilation, ventilator free days, etc., etc. So, too much fluids is actually bad. But what are the recommendations for a patient with septic shock who comes in your emergency department? Give fluids. So, in a day-to-day life, a physician is torn between giving too much fluids as well as restricting the fluids that is to be given. Now, let us see how we can use extravascular lung water. Now, how do you give fluids in septic shock patients? Today, we don't look at CVP, we looked at dynamic indices of fluid management. The aim is to give small aliquots of fluid and bring him up the ascending portion of Frank-Starling curve to achieve somewhere at this point, which is known as the optimal filling for these patients rather than overfilling these patients. Now, let us combine this with extravascular lung water. If you combine the two, we can increase at this point. If the extravascular lung water increases, it is an ideal situation where you know that you have to stop fluid management. But what is more important is that there are many patients with septic shock where the pulmonary vascular permeability is already damaged. In these patients, you don't look at the curve itself, that an increase in the extravascular lung water with an increase in the pulmonary vascular permeability tells you that you have to stop giving fluids in this patient irrespective of where he is on the Frank-Starling curve. And these patients, if you need hemodynamic support, you have to look at other mechanisms rather than giving fluids in these patients. Weaning from mechanical ventilation, it says that if you have a transpulmonary thermodilation catheter in the patient, an increase in the extravascular lung water by more than 14% from the beginning of TP's trial to the end of TP's trial is an indication that weaning has induced pulmonary edema in the patient and it's going to be a failure. The authors don't say that you put a thermodilation catheter for the sake of weaning, but if it is already there, utilize the availability. Lung transplant, the quality of the lung transplant can be assessed, how much edema is there in the lung can be easily assessed if you have a transpulmonary thermodilation catheter. And a lot of studies are being carried out in prone ventilation to find out what happens to extravascular lung water when you prone the patient and ventilate the patient. Some studies have shown no response, others have actually shown an improvement in response. So in summary, extravascular lung water and pulmonary vascular permeability index is a bedside tool today. They are good prognostic indicators in a variety of critically ill patients. Probably it should be included as part of the Berlin definition of ARDS. It should be included at least in the future algorithms where you have to manage fluids. Probably this parameter should be included as along with the fluid dynamic responses. And the only thing that actually hampers the use of extravascular lung water is the cost of the equipment and the cost of each of these catheters, which comes to around 20,000 rupees at the moment. Thank you very much.
Thank you very much, sir.
Thank you for watching this video. Like, comment and share, and please subscribe this channel.